Good morning, everybody. Thank you for joining us today for the Insight APSAB webinar series. For today's topic, Baclofen, substance use treatment or a Trojan horse, presented by Anita Myers. I'd like to begin by acknowledging the traditional owners of the land where we are meeting, that is Meanjin, Brisbane, traditional to the Turrbal and the Yuggera peoples. And I would like to acknowledge the lands from wherever you are joining us from today, and to pay respects to elders past, present and emerging. I'd also like to acknowledge the carers and the people with lived experience also from whom we continue to learn. So today's topic is presented by one of our educators here, one of our nurse educators, Anita Myers. Anita has been working with Insight for a couple of years, and she has been a nurse for many years, and she has a particular interest in the area of legal addictions. So I'm going to leave it to Anita to unpack this for us, and she's going to be looking beyond the hype and digging deeper, looking at the evidence and what that might mean for this substance in terms of helpfulness and harms. So thank you very much. Welcome, Anita.
All right, so yeah, as Michelle said, I'm going to be looking at the evidence for Baclofen and where it currently sits. So, just my disclaimer to start, I'm a nurse and the information that I've got is my interpretation of the evidence that is available at the moment. So I don't routinely work with people that use Baclofen, but this is a whole bunch of research has gone into this. So just to start, what is Baclofen? So a little bit of background. So Baclofen, or beta-chlorophenyl GABA. So this was developed in 1962 by chemist Henrik Kerbel, and it was found to have potent muscle relaxant and analgesic properties. And as a result, it's been used primarily for muscle spasticity treatment due to MS, spinal cord injury or cerebral injury. And it's available in Australia on the PBS for that purpose in 10 and 25 milligrams strengths, and there's 100 per pack. Now, the normal dosages that you're looking for when you're treating spasticity is anywhere between 30 to 75 milligrams a day. Although occasionally hospitalised patients, this dose can be up to 100 milligrams. So how does it work? So the oral tablets have a bioavailability between 70 to 80% into the plasma levels, and peak plasma concentrations can occur within 1 to 2 hours. Now, despite the fact that that's a relatively short period of time, the actual onset of action or the relief that people get is highly variable between individuals and can range anywhere from days to weeks. Now, the other thing with Baclofen, if you're taking it orally, is it actually doesn't pass the blood-brain barrier very well. So the CSF concentrations of Baclofen have actually been shown to be 8.5 times lower than what it is in the plasma levels if you're taking it orally. It actually, one of the good things about it, if you're thinking about our clients or our cohorts, is that it has limited liver metabolism, so about 15%. It's predominantly excreted in an unchanged form by the kidneys and about 5% in metabolites. The elimination half-life is between 2 to 6.8 hours. So as a result, this needs to be administered 3 to 4 times a day in order to maintain therapeutic effects. So just to note, when I'm talking about doses, which I will at points throughout this, I'm talking about a daily dose. This daily dose will have been broken up into 3 or 4 times a day dosing. So a little bit of pharmacodynamics, so a bit of neurobiology. I am not a neuroscientist. And just again, my disclaimer here is that we are still very much learning about this. So, this is what we know. and this is what we don't know. Just to give you an idea, our brains are incredibly complex organs, and the interaction between different neurochemicals and different neuroreceptors is still something that we're still working on and we're still learning about. So I'm going to give you a very broad overview of it, but obviously it's very simplistic. So Baclofen is a GABA B receptor full agonist. So if you've heard of this GABA before, you might be thinking alcohol or benzodiazepines. They actually work on a GABA A receptor. So similar, but a very different receptor subtype. So there's actually 3 different lots of GABA, and GABA B is one of them. So GABA B produces more of a slow and prolonged inhibitory effect through these G-coupled proteins, which I won't go into, but just so you know, it is a different receptor from GABA A. And GABA B also works on your pre- and postsynaptic neurons. So on the presynaptic neuron, it inhibits calcium conductance, which basically means it's mediating the release of a number of different neurotransmitters, and particularly excitatory ones, so things like glutamate, but also dopamine and noradrenaline and serotonin. On the postsynaptic neuron, it actually hyperpolarizes the neuron by increasing potassium out and inhibits the signal transfer. So they think the spasticity actually, or its treatment of spasticity, is due to the GABA B neurons in the spinal column. But GABA B receptors are throughout a number of different areas in the brain, and they've been implicated in the pathophysiology of anxiety and depression, of addictions, of seizures. So both increasing the likelihood of them, but also inhibiting them, as well as learning and memory. So they do think that it's involved in a lot of different areas. So if interest in Baclofen as a treatment, particularly for alcohol use disorder, gained traction around the turn of the 21st century. Now, how it works in addiction remains still really poorly understood. So the predominant theory seems to be that through its agonist effects of GABA B receptor sites within this mesolimbic reward system or dopamine system, and consequently its inhibition, so if you remember that mediating of release of dopamine and glutamate in that system, is somehow normalizing this reward system that has been hijacked through continual substance use. Now, just so you know, this whole theory of dopamine and addiction in particular is grossly oversimplified. So you remember that picture I had earlier that's like, we know about this much and there's a whole bunch we don't know. This is something that, you know, is along that same sort of line. So they've actually found that, you know, both pleasurable response or pleasurable stimuli as well as adverse stimuli seem to result in the release of dopamine within this reward pathway. Also, there's a whole bunch of substances, alcohol of which is one of them, that don't actually drop that same amount of dopamine or large amounts of dopamine within this reward system, unlike other substances such as stimulants that do give a lot more into that. And yet they both seem to be implicated in addictive processes. So it's oversimplified, but that's kind of what they think what's happening. So for alcohol in particular, there are a couple of other theories. So one of them is they think that you've got this stress-relieving, anti-azilic or anti-anxiety effects of Baclofen that may reduce some of the cravings for people with alcohol use disorder, or that this stimulation of GABA B provides through a negative feedback loop for the whole GABA system, because it's your inhibitory system as a whole is your GABA, may mimic some of this alcohol-induced action on your GABA A receptors. So as I was saying, the brain is very complicated, and just because you're influencing one neurotransmitter can have other influences on other different neurotransmitters, just because it likes to hurt out. Well, my head in particular, everybody's head probably. So what is the evidence for Baclofen in substance use treatment? So I'm going to start off with alcohol because that's the one that it's primarily been associated with. So early promise for its efficacy as an anti-craving medication was actually shown in some preclinical trials with rats. So they do actually often use, if you want to see if a medication is going to work, and they start off with these preclinical trials, see how we go. If we get positive results from that, we go, oh, this actually might work in people. And then we start small, we get case studies and smaller trials and go from there. But a lot of the excitement around Baclofen actually came from a self-case report by Dr. Olivier Amissen. So Dr. Olivier, he is a French-American cardiologist who had struggled with addiction or alcohol use disorder for many, many years. So he had tried a whole bunch of different anti-craving, he tried various rehabs and psychotherapy, and nothing had really worked for him. So he's seen these preclinical trials and gone, oh, look, I've got nothing to lose, I'll give that a red hot go. And so he then puts himself on Baclofen, works his dose up, and actually gains what would be considered the holy grail of addiction treatment, an indifference to alcohol. So he actually didn't care whether or not he drank anymore. It was even more than just an anti-craving. It was I just don't care. And the results were actually sustained over a long period of time, and even after he weaned himself down and then off. So it meant that he could, which, I think most of our guys would like to do, is be able to go, I am going to go out and have a drink with my friends, and I can stop at one. I don't have that same sort of need for alcohol that I used to. And this was after having Baclofen. So a lot of excitement was generated from this. So following this, there was actually a number of studies where Baclofen was showing some early promise for use in alcohol use disorder. So there was significantly, statistically significant reduced relapse rates, increased numbers of days abstinent, reduction in cravings, and, a couple more case reports showing high dose Baclofen resulting in that sustained and complete abstinence. The other thing that could be really helpful with Baclofen is actually been shown, because you've only got that 15% of it that's been metabolized by your liver, it's been shown to be safe in liver cirrhosis. Even the Child-Pugh class C, which having a bit of a look, none of the other anti-craving medications, they might be happy with A and B, but C is the most severe. They seem to be quite anti it for C, whereas Baclofen, people seem to be like, yep, we're okay for that. So, and hepatitis C patients. So, it is giving people option that potentially, if you have got some pretty severe cirrhosis, there is some anti-craving option for you. So despite its early promise, there still remains significant contention around it. So the level of evidence of Baclofen's efficacy can probably be best described as inconsistent. So there's a number of studies or randomized control trials showing no, so I've got negative as in no effect, and a whole bunch showing quite positive effects. And so results from recent meta-analyses largely do not show any significant treatment effects, with it best showing increased abstinence but no change in consumption or cravings. So I had a bit of a look into these meta-analyses. So there was one done in 2018 by the Cochrane Review. Now, if you're looking at the Cochrane Review, they are generally considered the gold standard for any sort of systematic meta-analyses kind of thing. And they had a meta-analysis, which is basically, I should say, meta-analysis is pooling a whole bunch of studies together to find a result. So you can get a far larger pool of people in order to show whether something does or does not have an effect. So they found that there was no difference between Baclofen and placebo for return to any drinking, frequency of days abstinent, frequency of heavy drinking days, and no reduction in anxiety. In fact, the only difference they did find was that Baclofen seemed to be increasing levels of depression in people. So they were, not very excited about it. In the same year, however, there was another systematic meta-analysis, which systematic meta-analysis, someone's getting real fancy with the titles. It's basically the same thing as the Cochrane Review. They're all meta-analyses, but they've just decided to put a systematic in front of it. So another one was done that looked at 14 different randomized controlled trials, which resulted in about the same number of participants. So they found that Baclofen had a small but statistically insignificant superiority in the over placebo in abstinence and level of drinking. Now, just a bit of a note about statistical significance. I apologise to any statisticians out there. Again, I'm going to try and keep this as simple as possible. But basically, it's for something to be statistically significant, we go, we are 95, they normally pick 95, 95% sure or more that this range or this effect is not happened by chance. And oftentimes you've got a confidence interval that can range, it can vary quite a bit. So to say that it is statistically insignificant, saying, well, we cannot say with 95% surety that it actually has a superiority over placebo. And then there was a third one, also done in 2018, that looked at 12 randomized controlled trials and 590 participants. So they actually found that it had increased rates of abstinence, but no change in cravings, heavy drinking days, depression, or anxiety. So I felt a little bit like the guy that I have on the screen there when I was looking at the three of these, because they're coming out with quite different conclusions. So we could say that the smaller of the third one, or the one with the smallest number of participants, that potentially their choice of studies were very different from the other two. So, maybe that's why they've gotten quite different results. But the other two studies, similar number of trials, similar numbers of participants, but two very different outcomes. And actually, I had a little bit more of a look into why they came up with the conclusions that they did come up with. And actually, that confidence interval I was talking about, they both the Cochrane and the one by Bashore had they both sat very close to no effect, but slightly positive. But with that confidence interval that they said it's somewhere between these two ranges, went from a no effect or a negative effect to a positive effect. So actually, somewhere in the middle there is probably where it sits. So it could actually have no effect, or it could have a reasonable effect. Basically, at the end of it, we still don't know. So, but it is worth noting that you just have to watch conclusions if you are reading articles from authors, whereabouts this interval sits if you're looking for an effect. So if it's crossing a 0, then it could actually be it's no effect or a negative effect. Or if it's going quite high the other way, then it could be quite a large effect or a quite positive effect. It just isn't giving you, and we don't know enough. But it is also worth noting that an absence of evidence of effect is not the same as an evidence of absence of effect. So it's basically saying, I can't tell you that it does nothing, but I can't tell you that it does something either. So if we ignore the meta-analyses, we still have a whole bunch of studies that if you look even at the confidence intervals, there's a whole bunch that are quite positive, that, saying they're definitely positive and definitely good results, and a whole bunch that were minimal or no, or quite negative. So they don't actually mix at all. So what's happened there? So some of the studies had quite arguably flawed methodology. So many of them, or most of them, had a sample size of less than 100 people. Now, this is problematic because if your effect is small, then you need a lot of people in order to show whether or not it actually has an effect. So if you've got this wide interval that's sort of crossing a 0, I might need many thousands of people. I might need 10,000 people in order for it to be able to tell me whether or not this is actually going to work. So less than 100 is not really very helpful. I did find one study that argued that Baclofen's effect was significant if the person wasn't engaged in psychotherapy, which didn't really make much sense, and seemed like a very odd thing to be doing, to go, well, just have a tablet and that way we don't need to be doing any psychotherapy. So I just found it interesting. There's also, the studies weren't the same. So the interventions, how long they're on Baclofen for, the dose, what they titrated it to or didn't, inclusion of psychotherapy or not, they're all quite different. And even the outcomes they're looking for are slightly different, or how they measure the outcomes can be different. So it can make it very difficult to make a conclusion based off that. Also, the adherence to the intervention. So did the client actually end up taking the Baclofen as it was prescribed or not? Did they have anything else going on for them? But even the clients or the patients themselves, so differences in gender, the severity of their alcohol use disorder, their tolerance to the effects, so how much the individuals could take, as well as other medical and psychiatric comorbidities. So, like if you think about it, any of our clients that are struggling with a substance use disorder, they're not one set of patients. They might have stimulant issues, but they're a very broad spectrum of people. So there were some studies that had a little bit of a look and tried to narrow down what types of people might benefit most from Baclofen. And it did seem to be people with comorbid anxiety, although they did find that that study in particular actually found that there was no reduction in anxiety, but people that had anxiety seemed to do better with it. Right, this is going my screen. And patients with higher consumption of alcohol. Although, again, it didn't specify what higher was, but it did say if they had a higher level of consumption, that seemed to be associated with it. So, Baclofen dosage. This was the other thing, that there was actually a really wide dosage window of Baclofen used between various studies. So some of the studies looked at low dose, so between 30 to 60 milligrams a day. But there was significant variation between them, and it would be anywhere from this 30 to 60 all the way up to some of the highest ones were 300 milligrams a day. So, you know, that's up to 10 times higher between two different studies of how much people were taking. It can be quite large doses. So there seemed to be no consensus as to whether a particular dose, either higher or lower, was associated with an increase in Baclofen's efficacy. So there were some that had very low, that were on the lower end of the dosage spectrum that showed positive results, and some on the low end that showed no, and then vice versa with the higher dose. So some high worked, some said the higher dose didn't do anything. So what are some of the concerns that we might be having for Baclofen as a treatment for alcohol use disorder? So one of them is the side effects of Baclofen. So even studies that demonstrate a positive association for Baclofen for treatment of alcohol use disorder did have some quite severe adverse effects, particularly in your high dosage range. There was a French study that was an electronic monitoring database system that looked at, there was 47,000 people. So this was looking at Baclofen's off-label usage. They found a twofold increase in dose-dependent mortality with Baclofen versus other anticoagulating medications such as acamprosate and naltrexone. Now, again, unfortunately, with using something like an electronic monitoring database, you don't know how people are taking this. They don't know the exact doses. They don't know how compliant somebody's being or not being, but they've just found that, you know, it seems to have a twofold increase in dose-dependent mortality. So not amazing. The other thing is often high doses of Baclofen are required for effect. So there were many cases of people having doses greater than 200 milligrams. In fact, I think the highest I found was about 530 that somebody was taking per day to get an effect. So if you remember back to what it was for spasticity, and the recommendations were 100 milligrams for hospitalized patients, you are more than doubling that for a large number of people in order to try and get some sort of effect. So the problem is the adverse effects that you might be getting from Baclofen may occur far before you get any anti-craving effects. So what about for alcohol withdrawal? So again, theoretically, the stimulation of GABA B can mimic the effects of alcohol on GABA A through those indirect pathways. So there was a bit of research for Baclofen as an alternative or an adjunct in withdrawal. Also, if you think about it, its impact on your neuromodulation and glutamate might be helpful because benzodiazepines don't do that so well. So, you know, it could be helpful. Also, you know, it can be helpful to introduce an anti-craving medication at the same time as withdrawal. So we've already got some anti-craving happening for these people by the time they do finish their withdrawal. So then they've got this longer standing anti-craving already on board. Or, you know, if you're concerned about somebody, giving them diazepam or benzodiazepines, you know, if they've got a benzodiazepine use disorder, maybe I don't want to give them all benzodiazepines as well as trying to wean them off alcohol. So what's the evidence? So not much in a nutshell. As a replacement, the Cochrane did a review in 2019 that found some low quality evidence that when they then they looked at baclofen versus diazepam on CWAR scores, that they were the same, which sounds pretty positive actually, because it means it is a replacement, that it's obviously working the same. But they've concluded that, again, low quality evidence, far too small of a study to make any broad sweeping statements about it. As an adjunct for withdrawal, it does not appear to have any effect on improving the course of alcohol withdrawal. In fact, one ICU study found length of intubation and length of hospital stay was actually higher in people that had had the baclofen as an adjunct. So Up to Date, which is a treatment reference guide that's often used in Queensland Health, advises its use as an add-on for severe alcohol withdrawal. So what about other substances? So GHB withdrawal. Now, GHB is a GABA-B agonist, so the same as baclofen, and current withdrawal regimes often require quite high doses of benzodiazepines, so a GABA-A agonist, and it's not always effective. And it's often require these high doses, and much higher than you might see in alcohol withdrawal, for example. So theoretically, we're all of a sudden, instead of trying to treat a different GABA receptor, we've now moved on to the same one. So it, theoretically would be a superior alternative. Now, here's the problem. There is a gap between evidence-based practice and practice-based evidence. There isn't a huge amount of GHB withdrawals that are happening in this world. So it makes it very difficult in order to study this appropriately. You're not nowhere near as prolific as alcohol use disorder. So it is quite difficult to make firm conclusions to get enough study material to say that, yes, this definitely does. And so, yeah, I had a bit of a look and I could only find a limited number of case studies mentioning it, either as a standalone or adjunct treatment. Up to Date, that same reference manual does mention its use in particularly severe withdrawal symptoms that are refractory to benzodiazepine treatment. So also, because there's not a lot of evidence, there remains a lack of optimal dosing regime. So options that I found in literature include a preloading. So one study tried giving 10 milligrams 3 times a day for 2 days prior to the commencement of withdrawal and then treating it with benzodiazepines. One combined it with benzodiazepines, and a review of case studies looked at anywhere between 15 and 60 milligrams in literature, either with oral or IV benzodiazepines, or as a standalone therapy. So the following regime was based off a case report for GHB withdrawal of a 26-year-old female who was consuming apparently 150 mils of GHB, which is a lot. I was a bit confused as to the large quantity of it, and actually checked with one of the addiction specialists here who was like 50s high. So I'm a little bit dubious as to the 150. I think we might be overstating it slightly. I think she also said she was taking 1.5 grams of meth a day, which again, I don't know how you afford that, or how one would survive having those kind of doses. Apparently what we're taking, it makes for an interesting case report. I'm, again, as I say, a little bit dubious as to the 150 mils, but somebody that did have a dependence on GHB nonetheless. And this regime, she needed no PRN diazepam or extra diazepam. So like you would for alcohol withdrawal, they front-loaded her. So she was having up to 130 milligrams a day, split over, so you had 4th hourly dose of 20 to 40 milligrams of baclofen, and then also was having as required, so PRN is as required, 4th hourly, and the totals then went down from there. So it was 130, then 90, then 40, then 30, and weaned off. So they've also looked at GHB for anti-craving, and with the animal studies, it's looking pretty good. Human studies, there was an open label study, so people knew that they were taking baclofen. They found there was no reduced lapse rates, i.e. people were still occasionally lapsing or having some GHB, but actually reduced overall relapse rates, and the dropout rates were better compared to treatment as usual, which was psychotherapy. They did do a case series which showed that 30 to 60 milligrams, so on that lower dose, did have a significant effect, reducing relapse rates over 12 weeks. But again, it's 11 participants, so it's not very many people, but potentially some early data there. So Stimulants. So this is one that if we go back to Baclofen's use in addiction on that reward pathway, then theoretically it should be doing a lot for the stimulants, because that is the one that is dropping a whole bunch of dopamine into that reward system, far more than any other substance. So cocaine. So animal studies, looking good. Human studies, so there was one with 70 participants that showed reduced at 60 milligrams, showed reduced use. Although only statistically significant in this post hoc analysis, which, just to get a bit of statistical nerdery on there, means that there's a few different ways to run any data through statistical analyses. So the one they originally chose didn't work or didn't show anything, so then they tried a different one and it does. That can happen quite regularly. It doesn't necessarily mean that somebody's doing some statistical shenanigans, but it is just worth noting that they did have to try a few different ways in order to show this effect. And also it is worth noting that 3 people required hospitalisation. There was also another randomised control trial that was twice the size of that found 60 milligrams had no effect, or no statistically significant effect. So meth, again, animal studies looking pretty good. Human studies, so there was only one control trial of 88 people that found no significance with 60 milligrams of Baclofen. And in fact, the significance they only found was if somebody attended the counselling. So unlike the one for alcohol, where they said that it only works if they don't, with the stimulants, it only works if they do, apparently. So they've also tried it for nicotine, because it was looking good in the animal studies. And a human study that looked at MRIs actually showed that there was a decreased reward response, which, you know, if we're working again off that theoretical mesolimbic pathway, cool. It's decreased response to smoking cues using Baclofen. So there was a very small trial of 30 people, showed that there was a reduced number of cigarettes that were smoked over the placebo, but nobody actually stopped smoking. So with cannabis, they actually have shown or found that Baclofen appears to potentiate the effects of THC, which could be quite handy if we're looking at things from a treatment of spasticity point of view. So for persistent pain or things like that, maybe they could work quite well together. Doesn't seem to necessarily lead on to a whole bunch of people smoking cannabis going, I love Baclofen, but it's just worth noting. So there was a case series that looked at 6 participants that 120 milligrams seemed to reduce withdrawal syndrome, and a case report of decreased consumption and abstinence at 70 milligrams a day, but not very much. And there was an open label study that looked at 10 participants. So again, like we've got some very small numbers here that showed decreased craving for both cannabis and tobacco, but actually didn't change the consumption of it at all. So inhalants, they have actually tried it for inhalants as well. There was a case report series that showed that 51 milligrams showed a reduction in withdrawal symptoms. They've also tried it for opioid withdrawal as a replacement for clonidine. So they found that there was no difference in retention or overall side effects when compared with clonidine, although it did have less hypotensive side effects. So it is something that, you know, potentially, again, if somebody has you know, quite low blood pressure already and you can't give them clonidine, and potentially Baclofen could be an option, but we rarely suggest doing opioid withdrawal without using buprenorphine anyway. So it's just interesting to note they've given it a red hot go there as well. So they've also tried it for some behavioural disorders. So for binge eating, there was one open label trial, so 7 people showed reduction in binge eating. There was a placebo-controlled trial that also showed decrease, as well as a case series. So again, very different doses. You've gone from 60 up to 180, but you know, again, of these very small numbers of people, they do seem to have found effect there. They tried it for gambling with 17 people and they found there was no reduction, and it hasn't been much since then. So what are some of the harms that we would be getting from Baclofen? So one of the things that we're concerned about is the side effects. So most clinical trials report high tolerability of Baclofen. It has, however, been associated with some non-trivial side effects, with some trials describing rates between 10 to 75%. So a lot of people getting some sort of side effect from these medications. Now, frequently reported adverse drug reactions. So this was taken from that French study of 47,000 people. This is some of the drug reactions that people were reporting were occurring. So sedation, dry mouth, insomnia, confusion, or impairment of cognitive function, sweating, restlessness, seizures, muscle rigidity. These sort of, again, these are not nothing side effects. Some of the less common ones, but also ones that were found, were agitation and coma, which is never a good one, hallucinations, behavioural disorders, and some withdrawal syndrome. So what happens in a baclofen overdose? So prolonged baclofen toxicity may require, prolonged ICU admission and ventilation. So without timely supportive therapy can actually be fatal. So I had a look at the LD50, which is, again, an animal study that they do, that they look at the dose required to kill off 50% of said animals, rats normally. Then they found that it's about 145 milligrams per kilo, so greater than 10 grams for a 70 kilo adult. So you need a lot. However, overdoses that requiring ventilation were actually closer to 2 grams, although less than half of that if co-ingested with other substances. So even doses under 1 gram, if you have it with other substances, can result in needing ICU admission, which again, if you're not getting an ICU admission, potentially results in an early demise. So some of the symptoms of toxicity can include coma, so seizures and myoclonic jerking, respiratory depression, delirium. There are some cardiovascular complications, so you can get prolonged QT, autonomic instability, so fluctuations in blood pressure, and bradycardia. And also give you hypothermia and hypotonia, so lack of deep tendon reflexes. So full patient recovery from a baclofen overdose is often observed within 72 hours. However, baclofen toxicity, despite that short half-life of 2 to 6.8 hours, can extend far beyond the usual 4 to 5 half-life expectation for clearance. So oftentimes, you know, the symptoms that you'll have are going to go far beyond the 30 odd hours that you would think for those 5 half-lives. So the mechanism of this is actually really poorly understood. So they have found, and again, this study was done in the 70s it's referring to, but nobody's looked at it much since, that there was a second peak plasma concentration that peaked again with baclofen. And they've also shown that the half-life of baclofen from the CSF fluid may be slower than it would be for the systemic circulation. So if we think about it, this longer than expected period of toxicity and grim looking picture can result in a prognosis of imminent brain death. So, you know, somebody that's got no tendon reflexes and isn't breathing very well or much at all and is, you know, in a coma, going, okay, maybe this, you know, this whatever's, because obviously people don't always know that someone's taken a baclofen only overdose or a baclofen overdose. They think we've got some brain death happening. So I did actually find a case report of 2 different people, one of which had, they'd actually arranged an organ procurement for this person. So they had gone, this person is imminently about to have complete brain death. I think the only of the different trials they used to assess brain death, the only thing they found was the apneic test. So they breathed once. Otherwise, they thought they were pretty well brain dead. So let's get this organ procurement done because it is imminent. And this was started to happen before this person actually started doing purposeful movements on day 5. They went, oh, maybe they're not so much. And in fact, the second person of the case report was day 7 before they started to gain more consciousness. So this is a really long time and a heck of a lot longer than 30 hours. And actually, both patients did not have any long-standing neurological deficits. So they woke up. They did have some delirium initially when they woke up from ICU, but I think the longest person was in hospital for 24 days before they were discharged home. So I'd always wondered when, you know, in Romeo and Juliet, when Juliet's taken this poison and everyone's sure she's dead, I'd always wondered what she'd taken. as potentially Baclofen would have been an option. So, Baclofen's harms in Australia. So there was actually a study done by the New South Wales Poisons Information Centre that looked at the calls to Poisons Information Centre in New South Wales from January 2004 to December 2016. So during that time, they also looked at the PBS data, which again, that's not including private scripts, but there was a marked increase in the trend of Baclofen prescribing over this 13-year period, despite the unlikely rise in or incidence of spasticity, or even the rise of alcohol use disorder. So it seems to be that people are trying this, particularly for alcohol use disorder, as opposed to other things, or it's more popular in that cohort. And as you can see on the screen there, you do have a nice rise, both of the number of prescriptions, but also the exposure count then mirrors that. So some of the characteristics of the calls to the Poisons Information Centre, 71% were symptomatic, and the most frequent symptom was sedation of a GCS of less than 9, which as an ED nurse, we would always go, it's again a broad statement, but we'd say GCS 8, intubate. So basically, they're very, very sleepy and not very rousable at all, and we're starting to get worried about the airway. So 19% of those required ventilation at one point during this day, and 9% required an ICU admission. Now, the majority, or just about 63%, had some co-ingestions with them. So, they were having alcohol, antidepressants, antipsychotics, opioids. So there was a bunch of other medication that were co-ingested at the same time. So then I tried to see if there is any mortality data from Baclofen in Australia. So there have been case reports of overdose, particularly again if people are taking Baclofen with other substances. I had a look in the Pennington's overdose report because again that looks at the different overdoses to try and find out if Baclofen was mentioned. It wasn't. I actually contacted Pennington directly, and they said that it was coded under this muscle spasm group of medicines, which was involved in 17 deaths, 9 of which were unintentional in 2019. So these are not huge numbers. I think opioids are over 800 off the top of my head. So, it is, again, a small number, but if you're thinking about it, you are giving this as a treatment, as an anti-craving treatment, can still result in somebody's death. So what about misuse? So there's actually not a lot, I couldn't find a lot of literature on Baclofen use as a substance of misuse. So it's not been highly associated with high levels of extramedical use or recreational use, and is generally considered to be devoid of abuse potential. I really hate that term. It's a misnomer, but it is something that people throw out a lot. But because there's been plenty of pharmaceuticals over the years that they've gone, yep, this is devoid of abuse potential. It's fine. It's not addictive. And then we've had huge problems with it later. So generally considered that people aren't using it for that, but it doesn't mean that it's not. So there have been several cases, or the cases I did find, that report tolerance to the effects of and misuse of it. But it seemed to be associated with increased mood, sense of well-being and pleasure, and increased cravings. I did actually find a few case reports where people were intentionally recreationally using it to get high, but again, they were scarce. So I did actually look on Blue Light, which is one of the harm reduction message boards where people talk about their experiences with different substances. And people were saying that they were using it for euphoria, relaxant, elevated mood, increased quality of life, anti-anxiety, empathetic effects. So somebody described it kind of like MDMA, although they didn't like the after effects of it, and delirium effects. There were also case reports of people that were saying they were using it to potentiate the effects of opioids, as well as cannabis, but again, wasn't prolific on there. It is also important to note that somebody could be on a very high dose of this due to tolerance and trying to make it work as an anti-craving medication rather than seeking a high. But it doesn't mean that there aren't still case reports of people, I think the highest was about 530 milligrams, somebody just individually titrated themselves up to because they were trying to make this work. So they were trying to get an effect of it and just figured it was quite safe to just keep going up. And this was without the doctor's knowledge that they'd gone up that high. So withdrawal. So a rapid dose reduction or abrupt cessation, even if it's not being used extramedically, has been resulted in a withdrawal syndrome. So the withdrawal symptoms are thought to result from this rebound enhancement of that spinal transmission that's been blocked. So the excitatory state that you've now got in your spine after you remove all the GABA B stimulation, which can lead to autonomic instability and severe withdrawal effects. So the symptoms for off-label use of baclofen are likely to be more severe than what it is used for traditionally due to the higher doses that are being used. So obviously if somebody's on that 30 to 60 milligram kind of end of the spectrum, then it will look quite a lot like your standard baclofen withdrawal. But if you're having a lot more, it's going to be a lot more severe. And case reports describing the withdrawal phenomenon for that off-label use seem to mirror closer to what the intrathecal withdrawal symptoms are, which is something that, again, can be used for spasticity. And that's far more severe than the oral. But again, there are case reports, there's a little bit of bias in case reports. Nobody's going to go, oh, this person that was using 60 milligrams of baclofen for their alcohol use disorder withdrew off it and had these withdrawal symptoms that look the same as what I would be expecting for anybody that was on 60 milligrams of baclofen withdrawal. So I tried to find some sort of timeline for this more severe withdrawal, and it's actually quite difficult because there's not a lot of literature on it. But it seems to be the symptoms of onset are about 12 to 48 hours after cessation. So they have been described as having quite similar to benzodiazepine or alcohol withdrawal, and can include, so looking at things like tremor and insomnia, diaphoresis, delirium, tachycardia, seizures, autonomic dysfunction. So ones that, if somebody presents like this, you could quite, legitimately say you think they're having delirium tremens, particularly if they've got an alcohol use disorder. It mirrors or looks quite similar to that. They have also found one of the case reports had a person going with a temperature up to 42.5 degrees, which basically at that kind of level, you are cooking all of your organs and ending up potentially with multi-organ failure. So again, or they could be septic. So it is one of those, can be quite difficult to diagnose. So obviously the risk of withdrawal is the same as you would for anything. It's length of treatment, how quickly they stopped, and high doses. So how do they manage it? So they try to manage it with benzodiazepines for the most part, but they often worked out, or the ones I found that they got confused between alcohol withdrawal and baclofen withdrawal, they were pumping them full of benzodiazepines and it was doing nothing. So for the most part, they actually had to reinstate the baclofen and then slowly titrate it down. So I had a look to see how, what the product information said about withdrawal, and they said over at least 1 to 2 weeks is recommended. However, again, the product information also says have doses of less than 100 milligrams. So if somebody's on much higher doses, if you're using it for addiction treatment, then obviously it's going to need to be longer than that. However, if you do have somebody that wants to withdraw off baclofen or is withdrawing from baclofen, please contact your local clinical advisory service. So in Queensland, that would be our wonderful ADCAS team, just to, again, get some extra support around that. So is it a good substance use treatment, or are we, we're getting a Trojan horse where we're just introducing another substance that, again, our guys might have issues with and cause a whole lot of toxicity and harm? So arguably, I would argue that baclofen might hold the greatest promise to assist in GHB withdrawal. Again, you've got your GABA B and your GABA B, which, and we don't have a great, benzodiazepines aren't an amazing treatment for it. So potentially it could be quite helpful there. However, again, there needs to be a heck of a lot more research into that. For alcohol use disorder, firm conclusions about baclofen are difficult to make. So there's no optimal fixed dose. And the exact patient cohort that would benefit most from this still remains elusive. We've got a bit of an idea, but we still really don't know. For other substances, there really isn't the human data to back up its use. So just remembering that the absence of evidence doesn't mean evidence of absence. I'm not saying it doesn't do anything, but you do need to be really wary about this. And you do need to be weighing up the pros and the cons as to whether this is actually going to be helpful for the person that's sitting in front of you. And it certainly shouldn't be a first-line treatment. So you should be looking at risks and benefits. So as an anti-craving medication, Baclofen is sedating, particularly at high doses. So if you are using it for somebody with, that has an alcohol use disorder or is using GHB, both of which are also highly sedating substances, you are potentially magnifying the issues that this person might be having or the increased risk of toxicity if they are going to continue to use or relapse their substance while they're on these doses. So, and due to toxicity concerns, it should be limited in patients who are assessed as high risk of overdose. So those with a history of borderline personality or self-harm, or if somebody's acutely suicidal or even chronically suicidal, this is probably not a great medication for them because they can kill themselves with this. And you do need to weigh up the required dosage to get some sort of anti-craving effects. So the majority of the adverse effects they've found seem to be over this 100 milligram threshold, although it's not exclusive to that. And if somebody's got comorbid physical or psychiatric conditions, again, increased risk of toxicity and harm. So it is something that, if you do decide to put somebody on this, then titrating it up slowly, going, well, if we're starting to get this 100 milligrams, is this really worth to continue to go on or not? And also sudden cessation of Baclofen has been associated with significant withdrawal issues. So particularly if you're using it for somebody with alcohol use disorder, it looks like somebody's in delirium tremens or can be mistaken for that. So it means that this person has delays in treatment. So you do need to be wary of that, particularly if somebody, can be impulsive or goes, if this doesn't work, I'm just going to stop taking it, which, some of the people that in the literature I found, that was what happened. It wasn't that they, got sick or anything. They just went, this medication is useless, I won't take it anymore. So it is, reinforcing to people and making sure that the person you have a good relationship with them and that they are somebody that's going to be compliant with therapy, not just suddenly stop taking stuff because it's not achieving what they want it to. So some safe prescribing tips or harmonization tips. So rapid increase or decrease of Baclofen should be avoided, full stop. Now there remains limited evidence for Baclofen as a use for substance use disorder, but people generally aren't misusing it, but having that close relationship with somebody and ongoing monitoring of the use of Baclofen is really important. So having that close relationship so that they will be telling you how much they're taking, whether or not it's increasing or not, or they're needing high doses or they're considering going off it. And also, because these are in packs of 100 tablets, even having a staged or limited supply of them could be considered, just because they come in packs of 100. So you do need to try and think about whether or not you split them into smaller packets. There is some recommended reading there. So this was that Poisons Information Centre. So that gave a nice overview of where Baclofen kind of currently sits in Australia. I would recommend, if you are interested, to have a look at that. And we've reached the end. These are all of my references. Feel free if you wish to fall down a rabbit hole. But yes, that is me done. Thank you very much. Do we have any questions?
Thank you so much, Anita, for all of that work. What a comprehensive review of Baclofen. I have learned so much listening to you. We have the odd question and comment online. So I would encourage people, if they have anything more there. We don't have much time though, but I've been monitoring that. I might just ask if there's any questions from the people here in the room first. There's hardly anything left to ask, perhaps, because it's been so thoroughly reviewed by you. I think you've responded to this in many ways. Someone's saying, why are the prescribing rates increasing? This is from online by doctors when we know these dangers. In many ways, you've responded.
Yeah, I mean, I'm not a doctor, but I would assume that you're looking for something that, like if the traditional anti-cravings aren't working in particular, and there is excitement online. I've found, I was looking on Reddit this morning to see if there was anything, and there's an Baclofen where, they are talking about its use in alcohol, and people that it's worked for love it and can be quite preachy and quite evangelical about it. So then, you know, somebody will go, okay, well, I want this, you know, that if something can offer, the other anti-craving medications don't offer that holy grail of I will be completely indifferent to this substance, then I can see why they would be asking for this, or why there is potential excitement around it.
And I think where my mind goes to is comorbidities. And I remember you saying that was one area, at least with alcohol, where that might be more useful with high levels of anxiety, high levels of alcohol use, which is a lot of the people we might see. I guess I was just interested too in any of your thoughts in those reviews around the psychological disturbances, because you did mention that, and that's something that we often see, and pain as well. Just if there's anything more you can refer us to there.
Not much from what I can, not much from what I've seen. So they did seem to show that, you know, if you mean like so they had some of them that seemed to, you know, show that it increased depression, and some of them seemed to show that it was better in people with anxiety, but it didn't seem to fix their anxiety. So it doesn't seem to do much for that. With the persistent pain, again, I think if you're talking about spasticity, it's again looking at a different pain pathway. So there's not much around whether or not it's helpful because it takes away pain. That was not something I found when looking at it for alcohol.